Oh yes, you made the right choice coming to my channel and trying to get info on Lambert Eaton Myasthenic Syndrome. Yes, you're welcome to my channel. Thanks for listening to my presentation, sharing all my presentations, and remembering to subscribe if you haven't. If you have, thanks once again. Today, I'll be addressing Lambert Eaton Myasthenic Syndrome. Is that strange to you? Really? Don't worry, in a bit, you know everything. Oh, not strange to you, okay? Let's have a review together. Lambert Eaton Myasthenic Syndrome. Fortunately, Lambert Eaton Myasthenic Syndrome is uncommon. It is a neuromuscular junction transmission disorder and majorly leading to muscle weakness. Here, we'll be dealing with acetylcholine that is low. So we're going to be dealing with decreased level of acetylcholine and also with antibodies against voltage-gated calcium channel. The acetylcholine is not released because calcium flux is blocked. Calcium flux means calcium in and out is blocked. Still on introduction to Lambert Eaton Myasthenic Syndrome, the incidence is unknown because it's uncommon. It is less when we compare these to Myasthenia Gravis. Don't be in a haste. Don't be in a hurry at all because I will compare and contrast Myasthenia Gravis and Lambert Eaton Myasthenic Syndrome right here today. So in the next few slides, we'll reach that. Half of LEMS is associated with malignancy, and that will be paraneoplastic syndrome, particularly small cell lung cancer. What are the possible clinical features? It is slowly progressive, affecting proximal muscles leading to weakness. So slowly progressive proximal muscle weakness, and the presentation could be acute or subacute. 3. Muscle activation vigorously will lead to an improvement in muscle strength and also an improvement in deep tendon reflexes. You know what? You can only get these in LEMS. Permit me to just use LEMS for Lambert Eaton Myasthenic Syndrome from now to the end of this presentation because it's going to reduce the time. Okay, still on clinical features. Paraneoplastic LEMS means we are dealing with LEMS today because there's an underlying malignancy which have more rapid progression of neurological symptoms. And for detailed presentation on paraneoplastic syndromes, you can check my channel. I have that published a while ago. 5. Paraneoplastic cerebellar degeneration can coexist with LEMS, but there are certain features that will distinguish that. There will be a high titer of voltage-gated calcium channel antibodies. 6. There is that likelihood of difficulty rising from the chair or abnormal gait in anyone with LEMS, and why that is due to muscle weakness. How about muscle fatigability? They're likely going to have it. They can have muscle cramps after exertion. Proximal muscle weakness will occur without atrophy, and there's likelihood of ptosis. Still on clinical features. LEMS with paraneoplastic cells, which means paraneoplastic LEMS is more rapid, and there will be more weakness of the proximal and distal arm muscles and also distal leg muscles. I think we got that right. Okay. Usually, the presentation of the weakness of the muscles will be symmetrical. The weakness could be regional, for example, proximal legs, or a complete limb, could be ocular, could be oropharynx, or respiratory muscles alone. There is a Bessel phenomenon or post-exertion or post-activation facilitation, and that is definitive in LEMS, and it's quite different. Still on clinical features, might be dealing with autonomic dysregulation in LEMS, and that will lead to dry mouth, symmetric and sluggish pupillary light responses, erectile dysfunction, blurred vision, and of course constipation. Still on clinical features, there will be less cranial nerves involvement when we compare LEMS to Myasthenia Gravis. And the few common cranial nerves that will be involved are going to lead to ptosis, diplopia, oropharyngeal dysarthria, dysphagia, difficulty chewing, hyporeflexia, paradoxical eyelid elevation compared to Myasthenia Gravis with fatigable ptosis. Okay, respiratory failure only at the later part of the disease, and that will lead to death. Diagnosis. Good enough that LEMS could be diagnosed clinically. So, thorough history and thorough physical examination. Is there a proximal muscle weakness here? Yes. About 1 to 17 clinical features, have we checked them and some of them are present? Yes. Then clinical diagnosis could be made right now. That is the way it is done mostly. However, before you're going to label that person as having LEMS, that is having Lambert Eaton Myasthenic Syndrome, let's have confirmatory test. We can have repetitive nerve stimulation, anti-PQ type voltage-gated calcium channel antibody, could be acid. We can have nerve conduction studies, needle electromyography, single fiber electromyography with voltage-gated calcium channel antibody testing, and about 90% of LEMS we have antibodies against the PQ type voltage-gated calcium channel. That is specific for LEMS. We can search for the possible malignancy if we are not suspecting paraneoplastic syndrome. We have to look for the cancer responsible, and mostly in LEMS, it is small cell lung cancer. What are the possible differential diagnoses? We may be dealing with MG, that is Myasthenia Gravis, limb girdle muscular dystrophy, polymyositis, acid maltase deficiency, polyneuropathy, polyradiculopathy, multiple cranial nerves mononeuropathies, Sjogren's syndrome, amyotrophic lateral sclerosis, multifocal motor neuropathy. Okay, right now, I want to delve into the differences between MG, that is Myasthenia Gravis, and LEMS, that is Lambert Eaton Myasthenic Syndrome. There will be a separate presentation later on Myasthenia Gravis and Graves' disease, and hypothyroidism, thyrotoxicosis, and thyroidostorm, and the rest. But I want to quickly run brief differences between the two right now. Myasthenia gravis is the most common neuromuscular junction transmission disorder, while LEMS is uncommon. MG has transient frustrating ocular symptoms of ptosis or diplopia, while LEMS has ocular and bulbar muscles that are generally spared or only mildly involved. Okay. MG will have less constant and progressive skeletal muscle weakness. LEMS, on the other hand, will have slowly progressive proximal leg weakness. In MG, the antibodies are against acetylcholine receptors. In LEMS, the antibodies are against voltage-gated calcium channel. In Myasthenia gravis, we don't have recovery of deep tendon reflexes on exertion. In LEMS, brief muscle activation will lead to recovery of deep tendon reflexes. In Myasthenia gravis, there are more cranial nerves abnormalities. In LEMS, we have less cranial nerves abnormalities. Is anyone still confused somewhere? Pause. Now rewind and play these differences again. Okay, 6 of them. And with that, no more confusion between LEMS and MG. Treatment. The most important thing is to get to the root of any matter, right? Let's look for the cause. For example, if it is paraneoplastic syndrome involved, let's look for the cancer, particularly small cell lung cancer. If we're dealing with very mild symptoms, let's just monitor. You know why? I personally don't like taking any medication, except if I'm, push the wall, take Tylenol or Advil. No. Aside that, I don't like. So prescribing it will also mean that the patient will truly benefit from the medication. So if it's mild, it's not affecting the daily life activities of the affected person, and we know the root cause, just monitor. Okay, but if we're dealing with moderate to severe symptoms, then let's have symptomatic treatment. Here, 3,4-DAP, which means 3,4-diaminopyridine, will be useful. We have to treat the cancer. Of course, the oncologist will help with the definitive chemotherapy or radiotherapy or even surgery, as the case might be. If we have enough positive and progressive result with 3,4-diaminopyridine, then let's continue with the same. If we are dealing with recalcitrant situation, then let's try intravenous immunoglobulin. If we are winning with intravenous immunoglobulin, let's continue with the same. But if we are not winning, let's try something else. How about prednisone with azathioprine? If we are achieving resolution with that, then we should start tapering off the prednisone, but leave the azathioprine on. If we are not winning with prednisone and azathioprine, we should try something new again, mycophenolate or cyclosporine. but we need to go over the possible complications or side effects of all these medications with the affected individual. If we are having enough progress, we can continue acetylcholine or mycophenolate. If we are not winning, we can try another thing entirely again, like rituximab intravenously, or we have plasma exchange. If 3,4-DAB is unavailable, that is our starting medication, or the patient cannot tolerate it, we can use guanidine, low dose, with or without pyridostigmine. Well, we will understand better, when it comes to pyridostigmine when we are treating all those cases later on. Prognosis. The treatment is more difficult and survival is worse when we are dealing with paraneoplastic Lambert Eaton Myasthenic Syndrome. Why that? Because of the underlying cancer. Lambert Eaton Myasthenic Syndrome with paraneoplastic situation, particularly in small cell lung cancer, is having prognosis determined based on the stage of the small cell lung cancer. In non-paraneoplastic LEMS, life expectancy is normal or close to normal. In other words, once we are sure there is no lung cancer here and there's no small cell lung cancer, and that this is not as a result of paraneoplastic syndrome, you can say bravo. The individual might live and die of another cause entirely. The non-paraneoplastic LEMS may not die quickly, but disability is likely. That is to say, the paraneoplastic cases might die faster than the non-paraneoplastic ones. In conclusion, Myasthenia Gravis and LEMS are very close, but closer assessment will reveal that they are quite different. For example, just rewind this presentation and go to the differences between the two. Thorough history and physical examination with or without confirmatory tests will help in distinguishing MG and LEMS. And with that, I've come to the end of this series. From the beginning, that is the anatomy of the thyroid gland, to the role of iodine in thyroid hormone synthesis, to how the thyroid hormones are synthesized, to the actions of thyroid hormone, to thyroid function test, to goiter, and now Lambert Eaton Myasthenic Syndrome, clearly distinguished from Myasthenia Gravis. Kindly remember to subscribe and share all these presentations with your colleagues and friends. And watch out, I will start another series on hypothyroidism alone. Everything you need to know about hypothyroidism will be published in the next 2 weeks. And after that, I'll start another series on hyperthyroidism. Anything you need to know about Graves' disease, thyrotoxicosis, thyroid storm, hyperthyroidism, everything will be published. Thanks for listening. Please remember to subscribe. I appreciate it.